Good afternoon, everybody. This is your eye expert, Dr. K, and today we just have a routine cataract case that we recently completed. We're going to create a side port that's parallel to the iris. Don't angle down because you'll have a higher propensity for leaks. Now we're going to inject some preservative-free lidocaine mixed 50-50 with BSS, really to prevent stinging or minimize stinging. We'll get our nice visco fluid wave, doing some viscodilation. And that bubble didn't come out, but often I will try and wiggle the cannula on the way out to get any air bubbles out of the eye. We use a 5 millimeter corneal marker, and then we make a 2.4 millimeter incision. I tend to make my incision slowly so I get the configuration that I want. When you see the tip getting towards decimes, you can angle the tip down just to make the entry into the eye. Also, when I use the stabilization ring, I tend to place the spikes or the teeth up so that they're not in contact with the sclera to avoid any subconjunctival hemorrhage. Now we use Utrata and a 0.12 to create a capsulorhexis, and I try and roughly follow the size of the 5 millimeter marker and also the outline of the iris um, to keep the capsulorhexis round and centered. This is a pretty uniform dilation, so we can stay equidistant from the iris 360 degrees and get a nice round capsulorhexis with the sizing based on the marker that I placed on the cornea. We're just taking our time here. You can probably do this in 3 or 4 regrasps. I don't know how many that was, but it was definitely more than 3, maybe 4, maybe one more than that. We will use hydrodissection, and then I do like to do some hydrodelineation once I see that the lens is spinning freely. You can see that this is a fairly dense posterior subcapsular cataract, so sometimes those do require a little more torque to spin them in the bag. But there we've got our hydrodelineation, a couple of waves. I don't really worry too much about how many different waves I have, as long as I get the lens mobile um, so that I'm not battling it. If it doesn't spin, I do change my technique slightly, just doing heminuclei and removing those individually. We reinflate with viscoelastic. We'll check our fluid flow, and then with our phaco handpiece, we clear the viscoelastic and anterior cortex and epinucleus in quadrant removal mode, and then we'll sculpt. I don't tend to sculpt too deeply, just enough to get purchase on the lens and divide it. So you'll see here just 2 swipes, and then you'll see that crack, and that's a nice crack. It doesn't have to go all the way to the bottom. You really do want to just crack that central nucleus. If you can get it to propagate more deeply, that's great, but it's not a necessity. We're just removing quadrants one at a time. Then we'll take up a heminucleus and kind of break that up. Notice that the phacotip stays fairly centrally in the eye and doesn't move a lot. Just getting those pieces out. Now we'll go for our epinucleus here, and you can see there's a couple layers of epinucleus because of the hydrodelineation that I did. There was a couple of layers of hydrodelineation, but the piece comes out completely. And then notice the position of that second instrument. It's blurry that it's so far back in the eye. Obviously, you don't want it to puncture the posterior capsule, but you want to keep that posterior capsule posterior. Now the epinucleus and the lens are removed. We're going to use IA to remove the cortex. In certain cases, you can get a complete cortical cleaving hydrodissection. But what I do find in those cases is that you do get a lot of cortical strands that remain. So for a cleaner capsule, I don't mind doing IA to remove the cortex as much as possible. It is an extra step, and it isn't necessarily necessary, but you don't leave any cortical strands. I do tend to power wash the capsule afterwards to remove any remaining cortex, and in this case, the remnants of that PSC. I try not to overdo it. You could use you could polish the posterior capsule with the IA handpiece, but I tend not to do that. Reinflate with Provisc. You've got a nice central capsulorhexis there. We're going to use our sweep to remove debris from the anterior capsule. And there's oftentimes a fair amount of debris that does get removed. Get that nice and clean. And then we will use our second instrument to stabilize the eye while we inject this Alcon Clarion lens. You can see that incision is nice and square. We'll get the lens in there, kind of wiggle it to make sure that it doesn't catch the lip of the incision. Place the lens in the bag. I do tend to use a Sinskey hook to make sure that the haptics are free and to get the lens in the position that I want. It just annoys me to have a stuck haptic that I'm waiting for at the end of the case. So I tend to just use the Sinskey to make sure that the haptics are liberated from the optic. We'll go behind the lens in Cortex mode and remove any Provisc behind there. And then once they come anteriorly, then that's usually when I will switch into viscoelastic removal mode. It's just a little more powerful. We'll sweep the periphery and then remove the viscoelastic centrally. One final time, I will use BSS to try and get any viscoelastic out of the angle. You'll see some freed up there just to make sure that there's no pressure spikes. And then we will seal the incisions, hydrate the sides of the incisions as well as the roof. And then side port. Side port usually seals pretty well if you have made the incision properly. We will inject some Moxie. Be careful of the concentration of Moxie you are using. Know what your moxifloxacin is. We will rehydrate and check the pressure. We'll make sure that all the incisions are sealed, and then we'll be done. And that is the case. I hope you folks enjoyed it. We'll try and get some more of these cases here for you.